Welcome to Health Professional Radio for this Health Suppliers segment. I'm your host, Neil Howard. Thank you for joining us. Our guest is Mr. Saeed Aminzadeh. He's joining us today as founder and CEO of Decision Point. And I'll let him give us a little bit of background about himself. And thank you for joining us on the program today, Saeed.
Yeah, I appreciate you having me. So we founded Decision Point back in 2013. And our focus then, and still is, on trying to help health plans improve their performance. So what we try to do is try to disrupt undesirable member behavior. Undesirable mean trying to reduce avoidable admissions and readmissions, trying to get members to get their preventive screenings, trying to get members to be able to be more adherent with their medications, trying to get them better access. And what we do is we take a data approach. We're trying to predict how people are going to behave. We're trying to predict what their barriers are, what their engagement with channels are going to be. So in theory, if you can predict how someone's going to behave, you can zero in on the people that are going to be highest risk and try to change that risk trajectory over time. So we've had some successes working with plans over the years, improving access, lowering avoidable admissions, improving preventive care, improving adherence. And we've shown that this stuff works, but it works best, really, it only works if we're working in partnership with our clients. So reviewing the information, they're taking action on the information that we provide them, and we're helping them gauge success and changing their approach and just becoming better over time.
What are some of the incentives for physicians to better manage their practices for these outcomes?
Well, that's a good question. Physicians more and more are kind of try to share the risk with the health plan. So meaning that a health plan might be at risk for Medicare star rating, so they get reimbursed more if they do well in their star rating. So if they do well in their preventive care, they do well in adherence, if they do well in access, if they do in avoiding utilization. So what they do is try to share that risk with the physician, meaning that the physician is also paid at risk, but this time instead of by the federal government, by the state, they're paid by the insurance company. So the incentive one is obviously greater payments by the insurance company. But the incentive there, I think also physicians try to do a good job. And if we're, as a vendor and as a partner of the health plan, are providing them with the right tools to do that, it just makes their job easier.
Why do you think that it is that the government didn't do some of the same things that the insurance companies are doing, seeing as how the insurance companies are going to save money, thereby being able to give more money? It seemed, I guess it was many years in the making, but why didn't the government come up with it first, since they were paying the doctors in the first place?
Well, the government, as with everything in life, right, you got to follow the money. And what the government does, and in fact, the government, it's odd, in our industry, in healthcare, the government is a change agent, and it's very different from other industries. And so the government, because they are paying for Medicare, paying at least partially for Medicaid, funding other types of healthcare, they have a vested interest in lowering the payment while also trying to keep quality high. And so they have joined into with risk arrangements with health plans, people that they reimburse. These health plans then get into at-risk arrangements with other organizations that they end up paying. So the government is, like it or not, playing a large part in really trying to change the landscape of care. And one of the things they've done is in the Medicare star rating. So basically saying, I'm going to pay you more or less depending on how you perform across a lot of different measures. One, you obviously got to do a good job of providing care to the members. What's the percentage of your members getting a mammography screen or getting the diabetes testing done? What's the percentage of your members that are adherent with their meds? So they're trying to judge these plans based on those metrics. And on the other hand, the plans are also under pressure to keep costs low because they're reimbursed on a member basis, not on a fee-for-service. So it's interesting. There's a pressure on both sides. One is to keep costs low. On the other hand, they need to spend money in order to be able to improve performance across some of those key metrics.
How much patient input is taken into consideration?
There is quite a bit of patient input, and it's probably a source of concern for plans, in my opinion. So a lot of these measures that the plan is at risk for is, some of them are not based on patient opinion, but based on things that happen. Did you go to the hospital? Did you get your screenings done? But some of them, like access to care, is based on a patient survey. The health outcome survey, that's another survey that's done. So there is a survey, and a plan's reimbursement is directly linked to what actually patients are saying about the plan, but also about their doctor, which the plan is on the hook for. So did you get the care you needed? Did you have to wait a long time to get the care? Are you happy with your doctor? Are you happy with your plan? Were they organized when you went to the doctor's office? So these are all questions that are asked about from patients, from members, and are directly then linked to how a plan is performing and how a plan will eventually be reimbursed. So it's all kind of, it's an attempt, like it or not, it's kind of an attempt at a closed loop to include the patient as well.
Very briefly, you said you've had some successes. Talk about some of, I guess, maybe the biggest challenge that you see in implementing these measures in support of these plans. What's the biggest challenge?
So the biggest challenge is trying to engage the unengaged patient, right? So you have a patient that is not going to the doctor, even though they're sick. You have a patient that's not getting basic preventive care. Sick or not, they may not be getting basic preventive care. The plan has a vested interest in doing that. The question becomes, how can you engage someone that really doesn't want to be engaged? So if you look at the retail industry, they have some advantages, right? You can go to Best Buy and you can walk out with a nice phone or a nice computer or a nice piece of electronics. Here, the plans are trying to sell healthcare, trying to get the person to, stay on top of their screenings, do a better job of taking their meds. It's not sexy. And so the biggest challenge is really trying to really focus on that individual and get them to engage better with their doctor, engage better with the plan, and get the care that they need. That's, I think, the biggest challenge in healthcare in general.
Where can we go online and learn more about Decision Point?
Yeah, thanks. You can please feel free to go to our website. It's decisionpointhealth.com is one word, decisionpointhealth.com. And also you can feel free to follow us on Twitter, DecisionPointHC. And I'll look forward to being in touch, and I appreciate the interview.
Thanks. Thank you so much for joining us today. You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to this podcast on iTunes, listen in and download at SoundCloud, and be sure and visit our affiliates page at hpr.fm and healthprofessionalradio.com.au.